All right, so today we're discussing Parkinson's disease medications. And I've talked about this topic before, and sometimes I feel like I bore myself a little bit. So I'm trying to take a different approach today where what I'd like to do is kind of walk you through the ways that medications might be utilized at different points in a course of Parkinson's disease and what options we might have for different particular symptoms at different stages of the disease. So I'm going to walk you through someone's experience with Parkinson's over an imaginary course of like 18 years, and that'll give us an opportunity to look at how the different medications might be used. And so the first point I'd like to make is that we do have a lot of tools in our toolbox with Parkinson's, and I think it can be a little bit anxiety provoking when you hear that somebody you know in a support group was started on this medication and you've never been offered that. So I'd just like to drive home the point that there are many reasonable approaches, and it's more of an art than a science, really. And we try to use the evidence that we have in our clinical experience, what we hear back from patients, to inform our decisions going on with other patients in the future. So let's discuss how this might start out. I'm looking at my schedule for the day. I have a new patient, and she's referred for tremor. So she's a 59-year-old woman. Her primary care doctor sent her to the neurologist because she started to notice an intermittent tremor in her right hand, and she's right-handed, and sometimes this causes her to feel a little bit self-conscious. The tremor goes away pretty easily if she does something purposeful with the hand. And she also has noticed some smaller handwriting, so that her husband has a harder time reading her grocery lists, and the handwriting gets smaller the longer she writes, and it may slant up a little ways over the course of a line of writing. She's noticed some softness in her voice. She has to repeat herself more often, and she works as a school principal, so she wants to be commanding and be well heard by her students, but her voice has become a little more quiet. And when you probe a little bit further, her husband says that she's really acting out dreams a lot at night, and she's been doing that for a couple of years, where deep in the night when she is in REM sleep dreaming, she might have a dream that she's fighting an enemy, and she's actually doing those motions and yelling out, and her husband's gotten slugged a couple times. So, yeah, exactly. So I am, as the neurologist, examine this patient, and what things am I looking for? Well, this is a talk about meds, so I don't want to get too bogged down in all the different symptoms, but we notice that she does have a rest tremor in the right hand. It's asymmetric, and it goes away when she does something purposeful, but she also has a little bit of rigidity and slowness of movement in that right side. It's pretty subtle, but enough to be concerned. And this dream enactment behavior is kind of suspicious because that can often precede the motor symptoms of Parkinson's for several years. And so it's a bit of a clue. It's kind of a supportive finding that the person describes that. So I tell her that, unfortunately, I think that her concerns might be well-founded, that she might truly have some mild symptoms of Parkinson's disease. And we're not seeing any other explanations for those symptoms. She's not on any medications that should produce those side effects and so forth. So we have a long talk about what this might mean and what the options are. The first point I'd like to make is that the choice of this initial therapy, or whether to start therapy at all at this visit, is really an individualized approach, and what's right for one person might not be right for another. So these are some factors that you would want to take into account when you're deciding on treatment, when I'm making a recommendation to a patient and when the patient's deciding what to do for themselves. So the first thing is, what specific manifestations of the disease do they have? Do they mostly have tremor, or are they having quite a bit of gait difficulty and falls and balance problems? Are they having stiffness that's painful? Are they having, cramping in their muscles at night that's keeping them awake? So that's going to be one thing that influences our choice. Another really important thing is, what are the patient's preferences about taking medication? I mean, people have all different philosophies about this, and we need to honor those when going into our recommendations as well. What are their goals for, the medications? What do they hope the medications will achieve, for one thing? Another important consideration is the person's age at the time of the diagnosis, because as we'll see as we go forward, that younger patients are a little bit more susceptible to some of the complications that can arise with dopaminergic therapy that we use in Parkinson's. And on the flip side, older patients might be more susceptible to some of the side effects of the levodopa sparing strategies. So we're thinking about age in the sense of what are the vulnerabilities to complications of treatment and side effects, and also how long is someone going to need to be on these drugs. Other medications that the person is on or medical conditions could influence our choice, that we might want to avoid drugs that would have interactions with things they need to take for other conditions. And then the functional goals. So is this person still working outside the home, or are they caring for young grandchildren or what have you? So what are the targets of this therapy working? And then the level of physical activity. So these are just some, not an exhaustive list, but some of the things that are kind of rattling through my mind that I want to know about the patient and that I'm considering when I'm thinking about meds. So let's take a brief detour and talk about how the medications in Parkinson's work. And this is not going to be comprehensive because that's a 2-hour separate talk. But I just want to show you, and you've probably seen this before in other times that you've come here for other talks, this kind of cartoon of a dopamine nerve cell. So what we see here is the blood-brain barrier, meaning that what's happening on this side is happening in the peripheral body before anything gets into the brain. And there's actually a barrier so that some drugs, if they're too big or they're of a certain chemical characteristics, they actually can't cross into the brain. So that's no good, because we need the drugs to get into the brain to do anything for the Parkinson's disease, because that's where the problem is. So in Parkinson's, dopamine levels are low. So here you see kind of the steps that happen before dopamine is produced in the brain cell that makes dopamine. So you have tyrosine, it gets changed into levodopa, and then it gets changed again into dopamine, and then that's stored in these little vesicles and released into the space between nerve cells, where it's picked up by something called a dopamine receptor that will allow the dopamine to work properly. So all of these steps need to happen normally to have normal function in the brain and down the line in the motor system. So in Parkinson's, not enough dopamine is getting released here. So we have different ways of trying to augment that. We can basically replace it by giving you a medication that is levodopa, or we can trick these receptors into thinking that dopamine is there when it's not. Or when the dopamine is released here and it's cleared by these chemicals over here, we can block those chemicals so the dopamine is not recycled. And that has the net effect of increasing dopamine levels. So this is all very complicated, and we'll come back to this, but it just suffice it to say that most of the strategies we have for treating motor symptoms of Parkinson's do so by either boosting dopamine or augmenting dopamine in some way. And we'll go through some different ways that might occur. So again, no need to memorize this table. I just want to point out that there are about 6 categories of meds that we use for the motor symptoms of Parkinson's. And certainly there are non-motor symptoms of Parkinson's for which other medications would be employed, but we're not going to get into that as much today. So 6 classes, we have levodopa, dopamine agonists, monoamine oxidase B inhibitors, COMT inhibitors, anticholinergics, and amantadine, and we'll talk about each of those in turn. So now coming back to our patient, she's 59, she's working, she's noticing a little bit of tremor. It's not all that functionally impairing for her, but it's making her a bit self-conscious. Mostly she came in because she was worried. She was concerned she might have Parkinson's, and in fact that concern seemed to be well-founded. So our first option treatment-wise is we don't have to start a medication right away. If this isn't really interfering with her ability to do her job or to do anything she wants to do day to day, then there's really not a lot of urgency at this point. We would encourage the person to exercise if they're not already doing that. If they aren't exercising, to kind of ease into an exercise program that suits them. We'd encourage them to get plenty of sleep and to try to minimize stress, which is good advice for all of us, but hard to do. So that's option 1. Option 2, we could go right to the gold standard. That's levodopa. That's the really one of the oldest and best, most effective treatments we have. The brand name you hear most often is Sinemet. Why fool around? Let's just go right to the best thing. Well, why wouldn't we want to do that? There are some reasons that we might want to save that. This person's pretty young. She's only 59. She's going to be on treatment the rest of her life, possibly. Even though that's the most effective thing, she's pretty young, so she might be able to tolerate some of these other strategies. So then option 3, we could consider a levodopa sparing approach, where instead of going right to levodopa, we would use one of these other classes of medications first. And those are the 4 options there: a monoamine oxidase B inhibitor, a dopamine agonist, amantadine, or an anticholinergic medication. So the patient thinks about this and decides, things aren't really so bad. I think now that I know what's going on, I'm just going to kind of sit with this for a while. I don't want to start a medication yet. That being said, because she does have the dream enactment behavior, I might recommend that she take some melatonin at bedtime to address that symptom. And so she's willing to do that because that's kind of a supplement. It's not a prescription. So she'll start that first. And then, I would have her come back in a short time frame because I want to make sure she's doing okay and give her an opportunity to ask questions that have come up with this new diagnosis. So I'll bring her back in a month. So now she comes back in. She's been thinking about this diagnosis and she's getting a little bit anxious about it. So I think one important point here is that you don't have to start a medication right away. It's a lot to take in. I don't think we really expect people to remember everything they hear in that first visit. And it, maybe not a great time to have to deal with both a new life-altering diagnosis and a new medication. So that's a fine approach. You just wait a little bit. So the patient is noticing that the melatonin's working. The dream enactment behavior has subsided. She's sleeping a little better, but she's a little bit anxious about what the future holds, and she has some questions about the prognosis and so forth. And she's becoming a little more self-conscious about this tremor now. Maybe even though her walking and arm swing has improved now that she's paying more attention to that, she's kind of thinking she's ready to start a medication. But she's read up and she's worried about levodopa. She doesn't want to use that right away. Okay, so in general, even though I told you before that there's not a lot of urgency to starting a medication right away, and that's true, early treatment is favored for a couple of reasons. One is that it allows us to keep people at their functional baseline for a longer period of time. We don't yet have a medication that's been proven to slow down disease progression in Parkinson's. But that being said, so that means that what's happening in the brain is not slowed down by anything that we could give you or write a prescription for. But I think indirectly, starting treatment when it's appropriate can help slow progression in the sense that it might prevent some of the secondary complications we worry about, such as, maybe you stop walking as much because you can't keep up with your spouse, and so then you get a little deconditioned, or you get a little bit of weakness in your muscles, or you get some secondary arthritis or something like that. Well, we want to avoid that. We want to keep you going to achieve your functional goals as long as possible. And, sometimes people are concerned that they think they should hold off on treatment until they can't stand it anymore because they're worried that the treatment itself is somehow toxic. And I think that was more of a concern like 20 or 15 years ago. Now there's some good long-term data that does not support that. So we don't think that there's any evidence for toxicity of these drugs. They don't accelerate the progression, even though they don't slow it down. And then if you consider kind of an extreme situation where people maybe wait a really long time or aren't diagnosed until they have quite significant symptoms, it becomes much more difficult to titrate medications in that setting because you need to ease into these medications. They don't work immediately for most people. And if we give them to you at a therapeutic dose right off the bat, you're probably going to have side effects. So we don't want to wait until you can't stand it anymore because it's probably going to be another several weeks or a month before the meds kind of get to where we need them to be. So we'd rather titrate the meds when you're not in crisis. So those are all some of the rationales for why early treatment is favored. Now, there's a little bit of data to support this as well. So this is just one example of a study out of the UK where they looked at people who started meds early in this group here with a single medication, that's monotherapy, meaning that they started one drug. And among these people who started treatment, about half of them started levodopa, and another good portion started a dopamine agonist, and another small percentage started a monoamine oxidase inhibitor. So they've all, kind of taken into consideration all these factors that we weigh about what med to start, and they've started something. Now in this group, you see people who did not start treatment, and then we have 3 points in time. 0 months, so at the time of diagnosis, 9 months later, and 18 months later. And in this part of the slide, you see that higher numbers reflect worsened quality of life or health status. And this is what the patients reported. So it reflected their mobility symptoms, but also just how they felt in general, and probably a lot of non-motor symptoms about mood and things like that. So higher is worse. People who did not start treatment at 18 months got worse. Okay? People who started treatment, they were pretty stable over 18 months. And so even though it might not slow disease progression, it might help people do better. So this is just one example of what we're thinking about when we recommend treatment. So now patient's already done option 1, no medication. She's done with that. She's going to consider options 2 and 3 now. So we again can go right to the gold standard of levodopa, or we can, let me talk a little bit about what concerns the person might have. So a lot of people come in and say, I don't want to start levodopa right now because I've heard it only works for a few years. Is that true? And that's not really true. People don't really get tolerant to it in the sense that the med's not working as well. What's happening is that the disease is progressing in the background, and so the deficit of dopamine in your brain is growing, unfortunately, and so it might look like that given dose is not working as well. But it's still working, it's just that you need more to meet the demand. And so that's really what can happen over time. So, and if you take people who have very advanced Parkinson's disease, they still do get some benefit from levodopa, certainly, and they're going to be much worse without it. It's just that we might not any longer be able to get you to normal. We might be able to get you to better than you'd be without medication. So the other concern people tend to have is that levodopa is more associated with developing dyskinesia or involuntary movements that are actually caused by the medication. So this is not tremor, but kind of wiggly movements that occur when the meds are working in your system. So is that a concern? Well, 50% of patients who start levodopa between ages 40 and 59 will develop dyskinesia by 5 years. So there's a lot of uncertainty in that statistic, right? I mean, for one thing, this is younger patients. People older than 70, only maybe 16% will have dyskinesia by 5 years. But younger patients are at higher risk. About half of them are going to get dyskinesia. Among that 50%, we don't know if all those patients are going to be bothered by the dyskinesia or not. But it's a legitimate concern, and we would like to avoid it if possible. So that's a factor that goes into our decision about using levodopa at this point. So then we can reconsider option 3, one of these levodopa sparing techniques. And so in this patient, we're going to think hard about a monoamine oxidase inhibitor. The examples of these are selegiline and rasagiline, and they work by preventing the recycling of dopamine in that space between the 2 cells that I showed you. So the reason that that's helpful is that your brain is still making dopamine at this point. It's very early on in the disease. And so this medication, it'll boost the effectiveness of the dopamine your brain is making. And if you're already taking a medication like levodopa, it'll allow that medication to work a little better as well. And one real big advantage of these is that they're very well tolerated for the most part, and they're only dosed once or twice a day. So this patient is really worried, she's still working. She doesn't want to be having to rely on taking something multiple times throughout the day. And she's also not wanting anything that's likely to make her sleepy or give her cognitive side effects. And so this would be a good choice for her. Another choice might be a dopamine agonist. Now, these medications are more potent. Traditionally, they require dosing 3 times a day, although now they all have a once-a-day formulation as well. Ropinirole and pramipexole are probably used more often. Rotigotine is in a patch form called the Nupro patch. And these when they came out, which was in like the mid to late 90s, I think the movement disorders community was really excited about them and was using them very aggressively at high doses, and now we recognize that they have some unique side effects that we need to be careful about. So they're longer acting than levodopa, and they might delay the onset of dyskinesia compared to levodopa, so they have those potential advantages. But they can also have a lot of problematic side effects, and we'll talk about that in a little bit. So this patient, remember, was worried. She didn't want anything that could make her thinking slow down or that could make her sleepy, so we might want to steer clear of this class of medications for the time being. So another choice that would be levodopa sparing would be a medication called amantadine. This is in kind of a class by itself. It's got multiple pharmacologic properties, and nobody really knows exactly how it works. And it does promote dopamine a little bit. It kind of inhibits dopamine reuptake. But it also acts on other neurotransmitters, which give it kind of a unique pharmacologic profile. It can be useful for tremor, and usually we dose this once or up to 3 times a day. It can have some side effects as well, namely it can give you some ankle swelling or a rash, and some people do get a little bit of confusion on it, or constipation, blurred vision. So there are some things to keep in mind there, but it might be an option for this patient, and it's unique in the sense that it tends not to cause sleepiness. If anything, it might help you stay awake a little bit, so sometimes we try to use it for that reason. Then the last option we had in the levodopa sparing was an anticholinergic medication, and I would just say that these are used pretty infrequently in my experience, and I don't use them a lot because really they're very difficult to tolerate. People tend to get constipated, sleepy, dry mouth, confused or forgetful. So we don't like to use them at all, in the elderly patients, and they're mainly helpful for tremor. So if you don't have much tremor, then this isn't a good choice anyway. But these medications were basically the only option before levodopa came out in the late 60s. So they were used a lot, in the early part of the 20th century. Okay. So the patient's considered all these options, and we've had a good discussion again, and she decides to start with something that's going to be low on the chance of side effects that she could take once a day. So she leaves with a prescription for Rasagiline or Azilect. All right, so now she comes back 9 months later, and we want to know how she's feeling and how her exam looks, and she's having some more bothersome symptoms. So at this point, her tremor is more obvious, and she's not sure if the Rasagiline is really helping the tremor. It seemed to help her handwriting a little bit, and she's not having any problems with it, but she just doesn't feel like it's really controlling her tremor. And she's noticing some more problematic slowness of movement with fine motor tasks like writing and typing and buttoning shirts, cutting food. She's a knitter, and that's becoming more difficult for her to manipulate her knitting needles. She still wants to continue working, and she's still pretty worried about levodopa. So what options do we have now? We need something a little more potent. So here's where I might turn to a dopamine agonist, because it is going to be more potent, and it's probably going to do a better job of addressing some of these slower movements that she's starting to have. And we just want to counsel her carefully about side effects. So the things that I like to tell people, and if it's not enough to scare you off, then then it's kind of a test if you're eligible for this medication, is that in about 10 to 15% of patients you can develop behavior changes called impulse control disorders, where you might develop some shopping tendencies or gambling tendencies that you didn't have before. It's kind of bizarre, but it's really attributable to the medication, and we certainly don't want anyone to suffer with that. These can have different effects on sleep. Some people get very sleepy on these medications. Other times it seems to give people some unnatural energy, and they stay awake all night taking up some sort of new hobby, which I think has a little bit of an impulse control disorder flavor to it. They're longer acting than levodopa, and because this patient is young and we're worried she might be at risk for developing dyskinesia, this might be a good choice because it might buy us a few years before starting levodopa. So we talked a little bit about the side effects. These two can cause some ankle swelling, and they also are, a little bit more likely than levodopa to cause cognitive side effects, meaning that they might make your thinking feel a bit slowed or feel a little bit spacey or even cause some mild visual hallucinations. So now the patient goes away. She's on rasagiline, the monoamine oxidase inhibitor, and she's on a dopamine agonist, so 2 medications for her Parkinson's. And, of course I would see her more frequently than every 3 years, but let's just fast forward a little bit. So she comes back 3 years later, and unfortunately she had to be in the hospital for a while because she developed appendicitis, and she needed an urgent appendectomy, and she didn't have time to plan or, educate her healthcare providers about her Parkinson's disease. Well, I think this is kind of a common scenario that people might go into the hospital for something completely unrelated to their Parkinson's and accidentally be put on meds that could mess your Parkinson's disease up. So let's talk a little bit about that. So PD-related complications are common in the hospital for a few reasons. One is that you never tend to get your medications the way that you would take them at home. So for instance, if you're taking your meds 3 times a day, but you want to get that benefit during the daytime hours when you're awake, you might take it breakfast, lunch, and dinner. In the hospital, the doctor orders it 3 times a day. In the hospital, that means every 8 hours. So you might go quite a longer stretch during your waking period between med doses, and then your meds are wearing off and you feel horrible. So that's one common thing. Another thing is that if you go in for something like a surgery, a lot of times the surgeons have like a list of orders that they put in for any patient they operate on, which would include a bunch of as-needed medications for nausea and pain and so forth. And some of these meds can really wreak havoc on your Parkinson's disease. So you could have side effects from commonly used medications in the hospital that shouldn't be used among Parkinson's patients. And Parkinson's patients are at increased risk of post-operative delirium. So meaning that like the effects of the anesthesia and the pain medications might hit you a little bit harder, and so more than half of people will have some confusion that's hopefully temporary just in the setting of having surgery or being hospitalized. So the meds that we think should be avoided in Parkinson's are in some broad categories of anti-nausea medications that block dopamine. And obviously if all the meds we're using to treat Parkinson's promote dopamine and boost it and increase it, we don't want to block it. That's doing the opposite. That's going to make everything worse. In fact, that can cause Parkinson's symptoms in people who don't even have Parkinson's disease. So common anti-nausea medications like metoclopramide or Reglan, Compazine, Phenergan, these all have some dopamine blocking properties and could negate the benefit of your Parkinson's medications or could just make your symptoms worse. So we'd prefer not to use those, and if you needed something for nausea, we'd use something that doesn't work on dopamine like Zofran, or Ondansetron is another name for that. Another big class of medications that should be avoided are antipsychotic medications. And this is a problem because I just told you that people with Parkinson's are a little higher risk of getting confused after surgery or during a hospitalization. And so one way that doctors in the hospital might address that, like if you're delirious and maybe seeing things that aren't there or talking to people that aren't there, is to use an antipsychotic temporarily. Well, that blocks dopamine also, and so it has the same problems as the nausea medications might have. And then narcotics can be more difficult to tolerate, so if you're being given something for post-operative pain, you might be more likely to get confused with that. So there are some strategies around this if you're having elective surgery, to go into the hospital with a list of things that shouldn't be used for you that are not allergies exactly, but kind of contraindicated meds, but that's hard to do in an emergency situation. So if you have a family or caregiver advocate to help you, that's good. And I think some of the organizations do have a list. I think the APDA has a card that you could carry that shows all the meds you shouldn't be given. All right. So the patient now, she's recovered from this hospital stay. She had a bad experience in the hospital, but she's pretty much now back at her baseline. But she's 4 years into her diagnosis, and she's 63 now. She's still on a monoamine oxidase inhibitor and a dopamine agonist so far, so 2 meds. And this hospital stay kind of threw her for a loop, but she's hanging in there now. But she's, now that you probe a little bit and say, well, how are these medications going? Are they working for you, and are they causing you any problems? It turns out she's having more sleepiness during the day, to the point where a couple times when driving, she's almost fallen asleep. And her ankles are kind of puffy, and so her primary care doctor was going to put her on a diuretic for that. But you say, whoa, stop the presses. That might be the dopamine agonist you're on, your Mirapex. So let's see if you actually need that diuretic. And then when you ask, carefully, the family says, well, it is pretty hard to get her away from the slot machines. We've been going to the casino, and she really doesn't stick to that limit of what we're going to spend, and she wants to go more and more, and it's becoming a problem. She's kind of, she's spending my inheritance, says her daughter. So you're worried now because the dopamine agonist might be contributing to that behavior. So just a reminder that I think one of the frustrating things in Parkinson's is that the medications and the goals that we're trying to achieve with medications is a moving target. So as the ancient Greek philosopher said, change is the only constant. And so we have to go into it knowing that that's going to be part of this, and that's what we need to prepare for to keep you doing as well as possible. So Parkinson's symptoms evolve over time, and now the patient has been through this stressful ordeal in the hospital. But also, when you examine her, her tremor is actually happening in both sides now, not just the right side. She's having more difficulty with fine motor tasks in both hands. And she's having some toe and foot cramping during the night and in the morning before she's taken her meds. So that's kind of a problem, and it's uncomfortable and painful, and it's affecting her exercise routine. So on exam, she's having a little bit more rigidity. So symptoms are just a little more noticeable, and they're not just on the right side now, they're on both sides. So because of these behavior things that her family's describing, and she's admitting to reluctantly, we decide to take her off the dopamine agonist, and we're going to need something to do the work of that medication now that that's going to be gone. So what do we do at this point? Well, levodopa remains the gold standard, and now I think we've given this enough time. She's 4 years in. That was a really good run without levodopa, and we don't want to withhold it if it's going to be the best thing for somebody. So let's talk a little bit about how that medication works. If you remember back to that picture, and I'll show it again in a little bit, levodopa is the most direct way that we have of replacing low dopamine, because it's one step before dopamine in the kind of production pathway. We can't give dopamine because it doesn't get into the brain where it needs to work. And so when we give levodopa, it's always given with something called a peripheral dopa decarboxylase inhibitor, which is carbidopa. So I think that leads to some confusion, because when you look at your prescription, you always see two numbers, and it's going to say most of the time like 25, 100, or 10, 100, or 25, 250. And that first number just tells you how much carbidopa is in there, and that's a little bit less important. The amount of the levodopa tells you kind of how strong the pill is, and so it's that second number that gives you the strength. So levodopa is converted to dopamine in the brain. It's still the most effective thing we have. It does not produce tolerance. I mentioned that before. And it comes in these several dosage forms, usually under the brand name of Sinemet. It comes in a controlled release called Sinemet CR that I tend to use mostly at nighttime or bedtime. It comes in a combination pill called Stalevo that combines another drug we'll talk about later. So there are a lot of different ways that we can give you levodopa, and now there are some even newer ways to give it that we'll talk about momentarily too, that try to achieve the goal of giving you kind of even symptom control over time. So levodopa, still the best thing we got. So here's that picture of the nerve cells again. So here's our dopamine-producing nerve cell that's underachieving because you have Parkinson's. It's not making enough dopamine. So instead, we're going to give you this levodopa that you take by mouth. The carbidopa is going to block the levodopa from getting metabolized in the bloodstream before it gets to the brain. That allows us to use a lower dose and reduces the side effects that you would have if we gave it without carbidopa. So then this levodopa gets into the brain, gets changed to dopamine, goes here, works where it needs to work, and she's still on the monoamine oxidase inhibitor that's kind of preventing it from getting recycled and making it work a little better. So that's what we're going to do for this patient now. Okay. Everyone good so far? Let me see how I'm doing on time. So we're going to fast forward 4 years because I want to illustrate for you some common phenomena that occur in kind of mid-stage disease where you can get some wearing off between doses and some dyskinesia from the medication. So the patient comes back. She's now 67. She's 8 years into her Parkinson's diagnosis. And she really feels like when her meds are working, she does great. She's able to knit. She's retired now, but she still enjoys taking walks with her husband. She's exercising. She's playing with her grandkids. She's doing everything she wants to do except for when her meds wear off. And her dosing schedule is such that she takes her levodopa every 4 hours during the day, but it's really only lasting like 3.5 hours. So there's some chunks of time in between her doses where she feels off. And when she's off, she notices more tremor, more difficulty buttoning her shirts, cutting her food, writing, typing, that kind of thing. She also finds it a little more challenging to get up out of a deep sofa when she's off. And then when her meds kick in, she can do that. So she's started to notice, too, that certain times of the day, especially like if she's in public or she's talking to somebody or she's feeling a little anxious or excited, that she's having some extra wiggly movements, and she finds that moderately embarrassing, and it's kind of preventing her from certain social situations that she would otherwise enjoy, and so that's a concern as well. So what am I hearing? I'm hearing that she's having wearing off and dyskinesia. These are kind of classic things that we want to address with our medication adjustments. So there are many strategies now. Again, not one blanket, one-size-fits-all approach. We have a couple different things we could do. We could add a COMT inhibitor or monoamine oxidase inhibitor, and I'm just going to go back for a moment to this picture here to remind us that those are the chemicals, the monoamine oxidase and the COMT. And COMT is here too in the peripheral system that metabolize or recycle dopamine. Normally that's fine if you're making plenty of it, but if you're not making enough, we don't want it to be recycled. We want it to work better and longer. So we can use drugs that block this enzyme or this enzyme to give you the net benefit of more dopamine. So we could add that. Well, she's already on a monoamine oxidase inhibitor, but if she hadn't been, we'd consider adding it. We could add a COMT inhibitor that kind of does the same thing. We could add a dopamine agonist, but in her case, we don't want to do that because we don't want to send her back to the slot machines. We could increase her dose of levodopa so that instead of taking 1.5 pills each time, now we'd say take 2 and see if it gets you from 3 hours to 4. Or we could think of strategies that would allow it to be more even in her system, like dosing it more often. You know, if it's working every 3.5 hours, why don't you just take it that often and add an extra dose in? Or we could think about some different formulations of the levodopa that would do that for her, like a continuous levodopa infusion called Duopa. So these are all different strategies for wearing off that we might consider. Well, option 1, add a monoamine oxidase inhibitor. You know, our patient's already on that, but maybe if she weren't, we'd add it now. We could add a COMT inhibitor to give along with each dose of levodopa and allow that to work a little longer. We could add a dopamine agonist if only she didn't have the gambling problem. Or we could adjust her levodopa. So we have many options available to us, and we have to think about the individual patient, what's going to make the most sense for that person. So our approach is always informed by her past experience and treatment, and so in this case, our options are kind of narrowed down to either adding a COMT inhibitor or a different formulation or dosing strategy of her levodopa. So how do COMT inhibitors work? Well, they're only given in conjunction with carbidopa-levodopa. They don't work as monotherapy the way that the rasagiline or Azilect did that she was on first. The names of these drugs are entacapone and tolcapone. And entacapone comes in a combination pill with carbidopa-levodopa that's called Stalevo. So that a Stalevo pill has 3 ingredients, carbidopa, levodopa, and entacapone. Or you can just give it separately as Comtan. There's another option there called tolcapone that's more potent. And the reason that tolcapone is more potent is that that works on the COMT enzyme both in the peripheral body but also in the brain, whereas the entacapone only works peripherally. So tolcapone's more potent and it works a little better, but in a few patients during the trials, they developed liver failure, so it requires liver function monitoring, and so most people aren't eager to have liver failure, so we tend to only try that if the other options have failed. Okay, so what about other levodopa options? Well, there's a newer capsule called Rytary that many of you may have tried, I don't know. And this is intended to have a timed release system where some of the medication works immediately when you take it, and then some of it is formed in different capsules that get digested at different rates, with the overarching goal of having it last more like in excess of 4 to 5 hours. So this allows you to achieve, it's supposed to allow you to achieve more on time, less off time, decreased frequency of dosing, so that maybe if you're somebody who needs to take meds 5 or 6 times a day, you could go from 5 or 6 to 4 or 3 times a day, which would be really nice. But overall, it's going to look like you're taking more because of the way that it works. It's not as readily taken into your system. So we've found that in patients where we've switched them to Rytary, we tend to have to almost double the dose. It looks like you're on almost twice as much medication because of the difference in the way that the bioavailability. What I found in my personal experience is that some people seem to benefit from this greatly, and other people, it's no better, and it's way more expensive. So, it's something that we would try, but it's not always the solution. So, and it's, the expense is definitely a consideration. What about Duopa? Well, that's a strategy where levodopa is infused actually via a tube. A tube is placed surgically or endoscopically into the intestine. You have an external portion that comes out of your belly, and that stays in place all the time. And it's attached to a cartridge of levodopa for which you set a rate of infusion. And it gives you kind of like a steady dose over 16 hours during the day. And then you take off the cartridge, you flush the tube, you don't have it on overnight. You wake up in the morning, you get your next cartridge out of the fridge, and you start the whole process over again. And the goal here is to prevent the ups and downs that taking a medication orally causes and give you more even symptom control. And in studies, it's shown to reduce off time by about 2 hours, which could be a pretty significant difference. That being said, I haven't had a lot of people like chomping at the bit to have this tube placed and have the cartridge and all of that, but it's certainly an option for some people. So this patient also described some dyskinesia, and in some ways we think about this in parallel to wearing off because they often do go together, and we would think about some of the same strategies to address it. So when dyskinesia emerges, we usually have several options. We can redistribute the meds, meaning, take a smaller dose more often. We can reduce the dose because, again, dyskinesia is caused by the meds we're giving you to treat motor symptoms of Parkinson's. And even though levodopa is most strongly correlated to developing dyskinesia, once you have dyskinesia, all the meds contribute to producing it. So, in other words, if you you have dyskinesia from your levodopa and you need a dose increase, and we add a dopamine agonist, you're probably going to get more dyskinesia as well. So it goes along with benefit, though, so that makes it a challenge. So we can redistribute, we can reduce, or we can think about adding amantadine. And again, I'm talking just about medication strategies because for some of these things, you'd actually maybe be thinking about deep brain stimulation surgery, and that's kind of a topic for another night. So these are our 3 options for dyskinesia. This is a chart that we see all the time in scientific meetings and movement disorders, and what it represents, I'll go through it for you, is here's somebody early in the course of their Parkinson's. This period of time is on time where the meds are working and doing what we want them to do, and this period is off time. So you have this therapeutic window where the meds are working well. You take the meds, it goes up in your bloodstream, and then it starts to slowly fall down until it gets out of your system and you need to take another dose. Here, this dark yellow is where you might have some dyskinesia. If the plasma concentration of the medication got into that range, you'd see some dyskinesia, but you're early in your disease, you have a lot of buffering capacity, so you don't have dyskinesia. Then as we go on into moderate disease, this dyskinesia threshold lowers. And that happens for a variety of reasons that I won't go into in great detail. Suffice it to say that the dyskinesia threshold is partly lowered because of the ongoing changes in the brain itself, where different neurons are being recruited to process dopamine that normally don't process dopamine. So this dyskinesia threshold lowers, and you start to see a little dyskinesia just at the peak dose maybe. Like, you take your meds at 8 a.m. and you're fine, and then at like 9 a.m. they've kicked in at 8:30, and at 9 you start to get a little wiggly, and then at 9:30 that goes away, and then the meds work for another hour or two, and then it starts to wear off. But as we get on into advanced disease, this threshold to turn on is a little bit higher, and the dyskinesia threshold is lower, and so we're having a greater period of time during which you have on time with dyskinesia, and sometimes it's hard to dissociate the on time itself from the dyskinesia because of this effect, what's going on pharmacologically, that you need enough medication to turn on, but that's the same amount that causes dyskinesia, so it becomes quite challenging, and that's why redistributing or reducing the doses might be one way you deal with that. So, or, maybe we can't afford to do that because your motor symptoms are so, tenuously controlled that if we reduce doses, you're not going to be on. So then we might consider amantadine, and that is the only medication of these that we've discussed that really helps reduce dyskinesia. And thinking back to what I told you before, we don't know exactly how it works. It does a lot of things in the brain, but one of the important things that we think is a factor in dyskinesia is that it acts on this chemical glutamate, which is an excitatory neurotransmitter, and it kind of reduces that. So that's a mechanism that's invoked for why it works for dyskinesia. And it doesn't eliminate dyskinesia, but it can reduce it by like 25 to 45%, which might be a meaningful change for some patients. And the problem is that it doesn't work forever. So some studies suggest that benefit of amantadine in reducing dyskinesia may only last like 8 to 12 months. Other studies have sort of negated that by trying to take it away from people who have been on it longer and finding that they do have some rebound dyskinesia. So just know that amantadine is a bit unique, and that it might be something we'd actually add if you're having dyskinesia, where many of the other drugs we'd be taking away. Okay, so now, again, please trust me that I've seen the patient more often than every 10 years. But now she's coming back 10 years down the road, and unfortunately now she's developed some cognitive symptoms and some visual hallucinations. So I wanted to talk a little bit about what approaches we might take with medication if this occurred. So she comes in now, she's 77 at this point. She, remember, was diagnosed 18 years ago, and I still look as young as ever. I look like I just got out of high school, and I'm still treating her. So she's coming back, and she's with her caretakers, who are her husband and her daughter. And they're concerned because she's noticing that she'll look out the window in the afternoon and think that some animals are out there that don't normally inhabit Wisconsin, like giraffes and things like that. But she kind of knows it's not real, and she says, "Oh, haha, it's those zoo animals are out there again." And it's not threatening. She's not really scared by it, and she's easily redirected. So they'll just say, "No, the animals haven't gotten loose from the zoo," and she laughs, and it's fine. But it's happening on a more frequent basis, and especially if the lighting is dim. And she's also noticing some more trouble with complex cognitive tasks like doing bills or managing finances or trying to put together IKEA furniture. She can't do that anymore. That's a real problem. So anyway, we're concerned. We're going to do a little cognitive screening test and see how things are going for her. And we think maybe she does have some mild impairment. And remember now that the patient is on a couple different medications. So we took away her dopamine agonist because of side effects, but she's on levodopa, and she's on a COMT inhibitor because we added that to help with wearing off. And she's still on her Rasagiline. So that's a monoamine oxidase inhibitor. And then she was having dyskinesia 10 years ago, so we had added amantadine, and she's still taking that. So she's on 4 different meds for her Parkinson's, and so what are we going to do with all these meds now that she's having these symptoms? So 66% of patients with Parkinson's will have at least mild hallucinations over the course of their Parkinson's disease. So I say that hopefully because if you've had that experience and it's been unsettling, you should know you're in good company. And for many patients, it's very mild. You know, it might be like looking at a pattern on the carpet or upholstery and it looks like a face when it's not, or something seems like it's moving and it's not really moving. You think something's scurrying in your peripheral vision and nothing's there. So it can be pretty mild, but for a smaller percentage of these people, it might be really severe or reach the level of kind of like frank psychosis where, you know, you don't know that what you're seeing is not real. And we'd rather sort of nip that in the bud and not get to that point before we address it. So when we hear this kind of thing from our patients, we think about streamlining the meds. So here we've gone through all these years where we're adding medications, adding, to try to better optimize your motor function. And now we're actually doing the reverse. We're going to streamline things and kind of peel it back a little bit. And I think that can be kind of, I'm sure it must feel kind of jarring to have that happen. Like, well, why did you put me on that if now you're saying I can't take it? And I would just point out that the vulnerability to side effects changes over the course of the disease. And so what might have been appropriate early on, it still was appropriate. It wasn't that it was a bad decision then. It's just that things have changed. You've gotten a little older. Maybe some other medical conditions have arisen. And so we have to reevaluate what's in your best interest. So if cognitive symptoms or hallucinations are a prominent complaint, I would take things away in a specific order. The first thing you'd take away would be any kind of anticholinergic, which we haven't even used here because I told you at the beginning that those are really hard to tolerate and they cause confusion. So we would, if the person was on that, we would take it away at this point. The next thing we would take away would be amantadine because that can certainly cause some confusion or even kind of trigger hallucinations. So we would taper that off. Then we would start reevaluating some of the other meds and maybe take away the COMT inhibitor and maybe rely on the patient's family or the pharmacy to help with, in lieu of that, dosing levodopa a little more frequently. If cognitive impairment seems to be an issue with the screening tests we do in the office, like meaning that the patient doesn't, has some struggles with memory or retrieval of information, or, many of you maybe have been asked to draw a clock. That's a test that we like to do. Maybe she has difficulty with that. Well, if that's the case, we can actually add a memory medication that promotes a different brain chemical called acetylcholine. So it works, it's kind of the yang to the yin of the anticholinergic. So where the anticholinergic that maybe we would have used back many years ago for tremor can cause confusion, we could use a medication called a cholinesterase inhibitor like donepezil, which is Aricept, or rivastigmine, which is Exelon, or galantamine is another one. And these are drugs that have been developed for Alzheimer's, but they can work quite well among patients with Parkinson's too, both in helping cognition, but also in reducing the chance that you'll have hallucinations. So they can help both of those things. And then maybe we try the cholinesterase inhibitor to see if the patient can draw a better clock next time, but it caused diarrhea because that's a common side effect, or it really caused a lot of weight loss, the patient's getting too skinny on us. So then we might add medication to actually mask the hallucinations, and some things that we use for that would be quetiapine or Seroquel, which is an antipsychotic, but it's one that has relatively few or low chance of causing motor complications, or clozapine, which is the best antipsychotic that we have, but for Parkinson's at least, but it requires weekly blood work to monitor your white blood cell count, which can be suppressed by this drug. So these are all different strategies. Now, I would always do number one, streamline the meds first, because maybe we can save you, the trouble of adding another medication if we streamline things. And it's always better to, I think, make your regimen more simple if you're having some cognitive difficulty. Now, there's a new medication on the market called pimavanserin or Nuplazid that's specifically approved for psychosis in Parkinson's disease. And it's kind of an exciting thing because it has a unique mechanism that it does not work on the dopamine system. It works on a different chemical called serotonin that you've probably heard of. But so far, pimavanserin, it's pretty new. It was just approved by the FDA like late this spring, and it's expensive. So I don't think we have a lot of experience with it yet, but the studies are very promising. So now this just gives us a little summary, and hopefully it's not too busy. I think it is, though. I'm always trying to reduce the words on this slide, and this has a few too many. But here's a timeline. So early Parkinson's, mild symptoms, monotherapy, one drug. Let's keep it simple. Let's make it easy for the person to dose it. And plus, you don't need a lot of complications at this point. Now things are getting a little more symptomatic. We're going to add a more potent medication or increase the doses. We would take the approach of rational polypharmacy, meaning that you're on more than one drug, but we've been thoughtful about it. We're not just adding them on without looking at what you've been given previously. Now here we're getting a little bit further into the disease course, some wearing off in dyskinesia. We can do more frequent dosing. We can add a dopamine agonist. We could add another medication to prevent the metabolism of dopamine. Or for dyskinesia, we can reduce, redistribute, or consider amantadine. And then we get into this stage here where we might see some more cognitive symptoms or hallucinations. And our options are streamlining meds, reducing doses, considering an antipsychotic like quetiapine, clozapine, or pimavanserin. So this is a very quick tour of how someone might, how the medications might be approached at different stages of the disease and what is going on in the back of your crazy movement disorder neurologist's mind when they're constantly changing your drug regimen and you can't, even keep track. So then the last point I'd like to make is that sometimes I'm really surprised to hear how much people are getting charged out of pocket for their meds because, to be honest, there seems to be like not much rhyme or reason to what one person gets charged compared to another. So if drug costs are a concern, please always bring that up with us. We don't always know. We don't have a good way of telling that when we prescribe something because many of these drugs, even if they're generic, can still incur a big expense to you. So there is a grant foundation called the Patient Access Network, and there's a number here and a website. And if you qualify, I think the income eligibility is like 500% of the poverty line, so that you don't have to be destitute to qualify for this, certainly. And it can give you up to $16,500 a year in prescription costs. So that's called the Patient Access Network Foundation. You could find it online, or certainly tell your prescribing doctor if prescription costs are concerned. Because we don't want you to be, we need to leave you some money for the slot machines. Otherwise, how would we know? Okay, so closing thoughts, and then there'll be time for questions. Medications certainly are one piece of the puzzle to living well with Parkinson's, but please don't forget, and this wasn't the topic tonight, but exercise is at least as important as medication to living well with Parkinson's, and that should be hand in hand with being on the right doses and timing of medication is that you're doing regular exercise that you can safely do that keeps you strong and flexible and all these good things. And in general, Parkinson's meds are aiming to restore more normal brain chemistry. So that's kind of the common theme to how the mechanism of action works. Is that, this is oversimplifying it, but Parkinson's lowers dopamine, the meds boost dopamine. Sometimes they boost it too much and they cause side effects like dyskinesia or hallucinations. But that's basically what we're trying to achieve. And then side effects might influence our treatment options and might narrow down the things that are available to you personally because we don't want to make you sick, just in an effort to stop your tremor. And please know that treatment regimens change over time, and you should voice any concerns you have about side effects or costs or what have you to your provider. So then I'll leave you with this, because I think change is the thing that you have to get most used to with this diagnosis of Parkinson's, and that if you can adapt to change and roll with it, then you're going to do very, very well with this. So I'll leave you there, and then if anyone has questions, I'd be happy to take them.
How does one get this list of the meds in case you have a problem?
Okay, so this is a great question. How do you get the list of the meds that you shouldn't be given? Well, one way that you could get the list is ask Jordan or go online to the American Parkinson Disease Association, and you can request a card or you can see the list there. But in general, it's anti-nausea medications, antipsychotic medications, some seizure medications like Depakote, and cardiac medications like amiodarone are the things that are on that list. Yes, sir.
Is it normal during heavy physical activity, like raising firewood, to wear off the on time, shorten on
Oh, that's a great question. So the question here was, is it normal for heavy physical activity like chopping firewood to make your on-time wear off faster? Is that fair to say? And yeah, I do hear that a lot. I think it's, I don't know exactly how to explain it, but I think it's kind of using up that dopamine a little bit more quickly.
So if you self-medicate, so you reduce your time, any disadvantage of that?
No, I think, so then the question is if you can self-medicate a little bit, if you need to reduce the time between doses, as long as you've kind of cleared that with your provider and you have enough medications in your prescription to allow you to do that, and you're not having side effects from too much medication, then I usually tell my patients that I trust you, you know your body better than I do, and it's okay to do that. But I would just caveat, talk with your provider about that. Yes, sir.
They're setting up nationally centers of excellence to standardize treatment, and I'm wondering what your percentage of match for those standards that they're working on.
So the question was that there are Parkinson's disease centers of excellence that are working to standardize treatment, and how would these recommendations match up? Well, I think it's safe to say that these recommendations that I've given you tonight are very much informed by practice guidelines and the evidence that's available to us and what's common practice among other movement disorders physicians. So this is, I don't think anything I've said is very controversial. And there are practice guidelines both through the National Parkinson Foundation Centers of Excellence and the AAN. And then I stay honest by working with excellent people like Nancy to kind of run things by. So I would venture to say that these all fall within normal practice parameters and recommendations based on the available evidence to us. Does that answer your question? Yeah, I think it's pretty well accepted. I would be too nervous to say something very controversial to you. Yes.
Dr. Manjan, can you speak to some of the research that's going on and some of the new medications that you're aware of or that are being developed?
Yeah, so I don't want to spend too much time on that just because I think there's a whole nother talk that maybe was recently given on research. Sorry. To repeat the question, what are some things that are in development or that are being researched for Parkinson's? There are many things that are revisions or improvements of existing treatments. So one thing I didn't talk about that much is here's just one example. There's a rescue medication for unpredictable off time that's injectable. It's a dopamine agonist called Apokyn. And I don't think people use it very much because you have to learn how to self-inject it, and it causes a lot of side effects. But they're supposed to be coming out with a version of that you'd put under your tongue, and it would dissolve quickly and work quickly if you were having an unpredictable off time. So that's kind of a reiteration of something that's already in practice. Another example like that would be that there are studies going on of inhaled levodopa. So the reason that you might do that would be that you have an off that's taking too long for the meds to work when you take them by mouth. You need something quicker. So you would take this inhaled levodopa, and it would work faster. So these are examples of meds that we already have, but we're always trying to improve on the delivery or the effectiveness of them or cut down on side effects. Of course, anytime we do that, what comes along with it is like that's a new brand name drug that's super expensive again. But those are some common examples. And then there are things that are like new strategies. An example I would give there would be medications that are intended or hoped to slow down disease progression. So an example there would be a calcium channel blocker called isradipine that's made it through phase 3 clinical trials. We know that it's safe, it's well tolerated. We're just not quite sure how effective it is at actually slowing down disease progression. So those are some strategies. And then there's a whole host of things like gene therapy and neurotrophic factors that are intended to promote brain health, allow your existing dopamine neurons to remain healthy and live as long as possible, and maybe to promote the growth of new dopamine neurons. And I would say a really good resource for looking at therapies in development is the Michael J. Fox website, because there's a whole section there that goes through where things are. So there are several phases of clinical trials, like phase 1, phase 2, phase 3, phase 4. It's not until you get to phase 4 that you're measuring whether something's actually effective. So if you look at the Michael J. Fox website under therapies in development, it'll give you all the types of things that are being looked at and how far along in the research they've gotten. And so I think that's a really good resource for things like that. Dan.
Yeah, about 3 slides back, you went through some of the financial things, but the slide's not real clear way back here. Can you maybe read the phone number and the website?
Sure. So the organization is the Patient Access Network, or PAN Foundation. The number is 1-866-316-7263, and the website is panfoundation.org.